To look at today's data briefly, system-wide, we have performed 892,860 tests, and 494,243 people have been tested system-wide with a positive percentage overall of 17.4%. And if we look at the hospitalized numbers for today, there were 31 people at Baptist Memphis in acute care non-ICU beds. That's 31, with 20 people in the ICU. That's 51 for today. We actually dipped down to 49, I think, for a couple of days ago, but hovering around 50 now. 16 of those 20 ICU patients are currently on ventilators. We have 80 ICU beds at the moment, and 71 of those 80 are occupied. You'll notice that as the numbers have gone down, we still have a fairly high ICU occupancy, and we've talked about that many times. Those ICU beds just fill up with temporary admissions from some elective procedures that require a day or two in the ICU. So that's a common factor along the way. We have 80 ventilators currently available in the building, and 43 of those 80 are currently in use. There are 5 fully vaccinated patients in the hospital with COVID-19 of the 51 that we have right now, and of the 6 new COVID admits over the last day or so, 1 of those was fully vaccinated. If you look at Baptist DeSoto, there are 28 COVID patients in acute care non-ICU beds, and there are 12 people in the ICU for a total of 40. 6 of those 12, half, are on the ventilator. They have 53 ventilators available in the building, and only 12 are currently in use. 3 of those 40 patients in the hospital are fully vaccinated, and of the 5 new admits, there are none who have been fully vaccinated. So those are the current numbers. I'm happy to answer any questions if anybody has any.
Hey, Dr. Threlkeld, one question that we have is about the guidelines for enforcing and lifting mask mandates. The last time we were below the average case count, the mandate was lifted. We're below it again, and it's still in place. So what goes into making that decision?
Yeah, it's a great question, timely, and in a way difficult. And obviously, I defer to Dr. Taylor and the Shelby County Health Department in terms of those guidelines, because they will be changing, and they change because of a number of reasons. The one listed and implicit in the question is, as community transmission goes down and as case numbers go down, obviously there will be a lower need for those mask mandates. I think there are a couple of situations that make it a little different from last time. So it's slightly more complicated than saying once we dip below the last threshold that we had, it would be just a repeat of that, simply because I think the price that we paid since then with the Delta wave obviously makes us a little more gun shy about these things. It's certainly harder to plant the flag and declare victory after what we've been through last time upon relaxing things, and also just the fact that the Delta variant is very different from where we were last time when we were looking at Wuhan and Alpha. Albeit more contagious than Wuhan, Delta is a level up on contagion. And so in that, I think would be an implicit potential problem of having the thing come back a little bit more quickly just based on our decrease in avoidance behavior, because it is it's a more contagious virus by a fair amount, at least twice. And, it's just a lot more dangerous to kind of rise up again if we relax too soon and squeeze more juice out of the orange there, we unfortunately being the orange in that analogy. So I think those two factors make it a little more difficult to be unconcerned about that. So obviously those deliberations will happen at the health department level and in the political level. But I think that all those caveats said, I think we're in very good situation moving forward, and we're in a better situation than before because there does not seem to be any particular increased contagion variant or increased resistance variant yet on the horizon. So we don't appear to be in a situation where, as we were just dismounting from the last wave, we saw Delta churning through other countries like India and really causing serious damage and deaths there. We don't have that yet, though. Again, just to restate, the concern is that as Delta goes away because of immunity, because more people have either been vaccinated or have had the disease. We expect that to go down, and it has gone down fairly sharply in every country that we've seen it in. Great Britain, India before us, in our section of the country today. Even though there are some areas in the country still that are having a fair number of Delta cases, ours are dropping fairly sharply. And in part, that's from immunity, both natural immunity from the infection and from vaccines. And so we expect that to come down, but that means that the next variant, if there is one, would probably more be one that would be resistant to our immunity, both vaccine and natural immunity. And we've already seen this occur in the world. Certainly, we've quoted the situation in Manaus, Brazil on several occasions. It had very high attack rate with the Wuhan variant initially, and then came the Gamma variant that really had little to no respect for that previous immunity, really tore through that population again, caused a great deal of disease. Thankfully, we've had very little of the Gamma variant here. There are a couple of cases, but really very few. And so we hope that that sort of thing doesn't arise. We would be very foolish not to at least have that at least in the back of our minds and to watch for that. But yeah, I mean, back to the question, I think that we're looking at a lot better situation. Hopefully we get back very quickly to where we were sort of at the end of June, where we really can begin to start relaxing things if things continue to go at the trajectory that they are now. Any other questions?
Hi, Dr. Threlkeld. This is Michaela Watts, Commercial Appeal. I'm standing in for Corinne Kennedy for a couple of weeks. I'm just curious because I've been interested in underlying conditions of our vaccinated patients that do wind up needing hospital care. And so I just kind of wanted to check in on those 5 and see if there are any trends there.
Yeah, I know about a couple of them. One was an older person that seemed to be kind of rather ill, turned out to be better off than we had feared, and is already going home in a day or so. So didn't really turn out to be very ill. So I think that it is staying the pattern that we have seen before. It tends to be folks with underlying immune system problems to begin with. So those people who are vaccinated, but from a practical sense, haven't been able to really garner the benefit from that vaccine because their immune system can't really generate that immunity very well for anything, vaccine included. So that certainly is a significant portion of what we see. And we've got a couple of examples of those, people with significant underlying health issues, either organ transplantation or the like. And then again, the elderly who've been vaccinated a long time ago. It takes a week or two for the booster to kick in and produce that extra immunity or that recurring immunity. So I think they're pretty much what we have seen before. There aren't many people that we see who are fully vaccinated in the young to middle age group without clear-cut immune deficits, and it's pretty much what we see nationally, honestly. So the number is just it just keeps the recurring theme is that the vaccine does continue to protect against the worst versions of this disease, i.e. resulting in hospitalization and death. And, one day that might change. It may be that the vaccine immunity will wane. And I think the best evidence for that sort of thing came in the elderly population when you looked at the Israeli data for the booster. And it's why some of the FDA panel members did not really recommend the booster for younger age groups. I mean, quite a few people in the FDA said it's not really necessary. The booster is great for protecting people with, or it's helpful at least, for protecting people with immune deficits and older people, which, if you really look at it, the oldest population probably do have immune systems that are waning a bit in their potency and their protection. So in a way, the elderly population, in addition to being the longest ago vaccinated, also tend to have some degree of immune deficit. So, what do we get in the younger populations? Well, theoretically, of course, it will cut down on those numbers of cases that are mild to asymptomatic. And so does that help us? The WHO would say absolutely not. And they would even say it's immoral and unethical for us to be doing this in the United States in the younger age groups in normal immune system people. They've been on record as saying this. They say that it's much more important to other places in the world and even to us looking out for our own best interest to suppress the replication of this virus in people who are unvaccinated. And since there are so many people throughout the world that are not vaccinated, even partially, let alone fully, that we should be concentrating on getting those people vaccinated. And there's something to say about that. There are a lot of people who would say, and some did on the FDA panel, as I mentioned, that yeah, we can probably get some lowering of the rate of cases that are asymptomatic to minimally symptomatic. Will that cut down on the replication of the virus temporarily? Yeah, it probably will. It might have some short-term benefit as we really try to squelch this virus locally completely as much as we can, but the likely benefit of that will be short-lived. And so by a year from now or 6 to 12 months from now, we'll probably be facing the same thing again. So we'll have to be looking at, if we're looking at protecting against any disease at all, we may end up being in a situation where we would need a vaccination every year. And are we really prepared to do that? Well, that's kind of a discussion to be had soon. But in terms of protecting against severe disease, there's not really any information that would suggest in the younger, healthy age groups that a booster really is going to do much about that.
Got it. Thanks, Doc.
Thank you.
Dr. Threlkeld, do you want to weigh in even briefly on what the FDA said today, that perhaps with the J&J vaccine, a booster of Pfizer or Moderna would be a good remedy, or that it might be given at 2 months instead of 6 or 8 months later?
Yeah, and you scooped me, Jane. I haven't seen the actual report out from the FDA yet today, but that's not a surprise to me. I think that in general, there were two thoughts about the vaccine boosters. We certainly had reasonable data from Great Britain that a Pfizer vaccine after an AstraZeneca vaccine did a nice job of bolstering immunity. So it's not a surprise to me that they would look at those data and say they have enough data now to suggest that mixing those vaccines may be a reasonable idea. Probably making that less important is the fact that Moderna and J&J have been on the cusp of getting approved for their own boosters. So in that sense, you would be having things that have shown direct trials that had good data about that. But it's not a surprise to me that either of those would be reasonably effective. And so we've certainly seen those numbers preliminarily from J&J and Moderna that suggested that they had a good outcome. As far as spacing out the vaccines, also, we saw that in Great Britain when they spaced out the AstraZeneca vaccine, and they found that there was actually a better immune boost. And that also is not a really large surprise, in that sometimes it takes the immune system a bit longer to really process all that, and a boost a bit later on can actually do a better job of creating those memory B cells that we talk about sometimes. Those cells that once the antibodies that we make from the vaccine drift away, as they almost always do over a period of months afterward, you're left with these memory B cells, and T cells for that matter. But the B cells are the ones that when they encounter the virus again, they awaken and they quickly differentiate into antibody factories and make a lot more of the antibody. And that's why you get a little bit of illness in some people once those antibodies wane away after months, but the B cells jump in and win the race to prevent us from getting more seriously ill. And there are examples, if you look at hepatitis B vaccine and others, that a vaccine going out 6 months after the first one can actually do the best job of generating those memory B cells. But almost to surprise, the RNA vaccines actually did a very good job of generating those memory B cells in people, even with the 2 or 3 week spaced vaccine. It's just the way they were tested in the beginning. But they were surprisingly effective at generating those B cells, even with a shorter duration. But there are some data out there, and it's not surprising to suggest that waiting longer between those vaccines may be even better at generating those B cells. So I apologize, I haven't seen the full data that you're talking about from today, but that to me is not a surprise at all that the data are building up in that direction.
One more question, Dr. Threlkeld, for your Memphis fans. Do you have any inside information when children 5 to 11 may be authorized?
Well, certainly the committee of the FDA is going to meet on October the 26th. And I think, at least from the statements of some of the members on that committee, I think they are favorably disposed to vaccinate younger kids. We haven't seen all the data that they'll be privy to, and sometimes they won't have seen it yet either. Those data, the full data from those trials, generally hit their desks week, 10 days or so before that meeting. So they have to digest that and then make the deliberations at the meeting. So I think we haven't seen all the data that we need to. And, people ask all the time, are you in favor of vaccinating kids 5 to 11? And my response is, just like I said for adults, I want to see all the data to be able to say that. I think from what we know of the data preliminarily, it looks very promising. And unless there are surprises in store for us in those data batches that they'll be providing the FDA, I think you'll see a fairly rapid movement of that, and it'll march through the process that we saw very recently in the booster process. It'll go to the FDA subcommittee on vaccines, and if they approve it, it will go to the full FDA, and if they approve it, then it will go to the CDC, again, a committee on vaccine practices, and then to the head of the CDC to make the final recommendations on really who should get it. So it's a multi-step process, which seems a bit bureaucratic and delayed, but I think we have to make sure that we look at safety and efficacy very carefully in our kids' population. It's a lower dose in these vaccines, but appears to be plenty immunogenic in the numbers that we've seen so far. So I think that kids don't get as sick from COVID as adults do. There's no question about that. But tell that to I have had a distant relative in the ICU for weeks from COVID-related problems in a teenager or young adult, actually, and so we've seen a lot of damage. 500 plus kids have died of COVID-19, and you say, well, that's not many, and people make that argument. And I suppose, again, unless you're related to one of them, but only 800 people per year or so die of drowning, and everybody's careful to put a life vest on people when they go to the lake. And so I think there's a fair amount of sentiment for vaccinating kids to protect them, and then also just as a portion of protection of the people around them. Those kids are around elderly folks and their family. So I'll be surprised if we don't see approval of that vaccine, and I'll be surprised if we don't see it, on October the 26th. It could actually reach through the entire process by a few days after that. So I expect into the 1st of November we'll probably have that passed.
Thank you.
Thank you, Jane. Any other questions? I have a couple from the feed that I'll answer. Vicki Jameson asked, after a monoclonal antibody infusion, should there be a delay in getting a flu vaccine? Very good question, one that we're getting a lot, and sort of the flu plus COVID is a very, very important and appropriately hot topic right now. So the monoclonal antibody infusion, and this comes from the idea that you should wait 90 days or so before getting a COVID vaccine or booster after you get the monoclonal antibody. So if you have COVID today and you have the monoclonal antibody, you will have circulating in your bloodstream molecules that will bind to the spike protein. And if the idea is that the vaccine causes your cell to make spike proteins to show to the immune system to make it mad and generate a response to that spike protein, if you already have antibodies in your blood who will stick to those spike proteins and cover them up so that your own innate immune system can't see them, then that will potentially decrease your ability to have that response to the vaccine. So that's why you don't take a COVID vaccine after a monoclonal antibody for COVID. Those monoclonal antibodies do not bind to influenza virus or the pieces of it that your cell might create, or the pieces of it that the vaccine presents to us. So there shouldn't be any problem in getting a flu vaccine right after monoclonal antibody for COVID-19. And I would say, just as a parenthetical item, I happened to get the booster and the flu vaccine at the same time on Monday. I thankfully had no problems really from either, but it's fine to get them at the same time because they don't interfere with each other. We've mentioned before that when the COVID vaccine first came out, there was a separation of 2 weeks between the COVID vaccine and everything else. That was purely a bookkeeping issue designed to make sure that whatever side effects we saw from COVID-19 were indeed linked to COVID-19 and not blamed on some other vaccine that could have been causing side effects too. So very important question to be sure. Vicky Smallwood-Tart asked if someone has an artery compression syndrome with collateral circulation, does that make them at higher risk for blood clots should they get COVID? So a hard question to answer, Vicky. I think that in general, I would say, and again, it's hard to apply this to any one patient, but in general, vascular disease would not make you more likely to have such a reaction if you were looking, for example, at the Johnson & Johnson low platelet count clotting syndrome, which is, of course, very, very rare. But it would just mean that if you had things like that, they would be more prominent and more problematic based on your underlying difficulty. So, a neurologic problem might not be more likely to recur in someone with some other disease that affected the neurologic system. But if you already had a problem there, it might make it more difficult. So I would say the answer is no, it does not make it more likely to happen per se at all. Isaac Kike asked, why can't you find a good immunity test? A very important issue and problem from the beginning here. We've talked many times about should you check antibody levels. About the only time I check antibody levels anymore is to see if someone has had the natural infection or how long ago. And I checked one in the hospital a couple times in the last week to see if someone who has a positive swab has had time to develop an antibody. And so they would have the total antibody or nucleocapsid antibody in addition to the spike protein antibody from the vaccine. There is no nucleocapsid protein in the vaccine, so you can tell if someone has had the real infection, a natural infection in the past. That's about the only time I use that anymore. But the problem with all of these antibody tests is that they don't test for neutralizing antibody per se. That's more of a research-based test. And so if you have neutralizing antibody, that really does correlate with your likelihood of getting a disease and more severe disease. But that test is not readily available with a simple blood test commercially that people can do. So the bottom line is that you can test things, they just don't correlate with actual protection. So a very important problem that we faced and something that people are looking at certainly to try to make that more operational later in this disease process and for others. And finally, Beth Kargauer asked, it seems like the vaccines first came out, they seemed to promise that the vaccine would prevent infection, not just hospitalizations and death. The effectiveness numbers seem to reflect a 94% protection from infection, initially that is. Was that just a false hope, or were they intended to only prevent hospitalizations and death? Some say that they were never intended to prevent infection, that we just got a little lucky for a while with that. Well, it is true that the protection against infection per se, asymptomatic or mild infections, has waned because of, in no small part, the Delta variant. But let's not forget, this has become a false narrative. People are saying that, well, it only protects against serious infection death. That's not true. It still protects up to 8-fold or higher against infection per se. So the idea that this vaccine doesn't protect you from giving it to someone else is just not true. It does, because if you don't get it, and you're many times less likely to get it with the vaccine, then you can't give it to somebody else. So it's an important point that I think is very, very good to bring up. It does indeed still prevent infections. We see a lot of people who are family members of actual infections now who don't get infected themselves. We don't see that very, very often with the Delta variant in unvaccinated people. It will really rip through a household with high efficiency at unvaccinated people. Are there exceptions? Always. But in general, I think that's a very good rule. So you're way safer to be vaccinated, both from standpoint of preventing serious disease and from getting it at all. And that's why I think that, I think even the vaccinated, being vaccinated when you're a healthcare worker, I think is very important, even if you've had natural infection. Those antibodies are helpful. There's no question. The idea that natural immunity doesn't protect you from serious infection and death, the idea that that's not true is silly. It does. I mean, natural infection immunity is important, but we have good trials showing that the vaccination on top of natural infection further improves your protection against any infection by 2 to 3-fold. And so if you work in healthcare, I think that that's a very important thing to remember, because you're trying to protect people who are immune compromised, people with difficulties you're taking care of. And we owe that to them to keep them as safe as we possibly can. And that's a point of frustration for me. The idea that we're protected even against severe disease by our natural immunity is great. It's important. But if we're trying to do the very best we can to protect those who can't get that immunity around us, I think that the extra immunity you get from the vaccine is just the best way to care for other people. So a very important point to make. Any other questions? Okay, thanks very much, guys. Have a good weekend.